Okay, we are sitting face to face, and you must close your loudspeaker. Okay, wonderful. I try to get my screen open, and this is what I want to show to you. I hope that everybody can hear me. Can you hear me? Oh, just a minute. No, you should be able to hear me. Can you just show me? Hien, can you hear me? Can you hear me? Okay. Okay. So I
hear you. Okay.
Okay. Thank you. So this is my question. This is the second Vietnamese virtual meeting. We had already one in January with Bach Mai Hospital, and it worked very nicely. So I'm convinced that this will also will work as we have done it, seen it before. Cardiac output measurement by echocardiography. Why is that so important? One thing is that we are all calculating the opening area of the stenotic aortic valve by continuity quotient. With the continuity quotient, we are using the subvalvular stroke volume as a reference for the transvalvular velocity. This is one point. The other point is that these are the newest guidelines of the ACC-AHA on mitral regurgitation, and you all know the discussion when we are talking about MITRA FR or COAPT study about mitra clip or interventional treatment of mitral regurgitation, and we have to objectivate that what we see in the severity of a disease. And what we see there in the guidelines, at least the American guidelines, now are regurgitant volumes, which have to be quantified, and we always are talking about the regurgitation fraction. And this has a lot to do with stroke volume measurements. And next is that we have to think about stress echocardiography, specifically for all kinds of valvular heart disease, but also for myocardial diseases. We should look for reaction, physiological reaction on stress, on heart failure, and specifically on the perioperative status of the patient, the ICU. We have to know something about the cardiac output and shunt calculation. Here you see typically a sinus venosus defect, and we have to calculate the shunt by comparing the flow across the aortic versus the flow across the pulmonary valve. So reasons enough to talk about that what we can do with echo for stroke volume and cardiac output measurements. And just to summarize at the beginning, the methods that we are using, we can use 2D or 3D flow area measurements, mostly for the left ventricular outflow tract, perhaps in some cases for shunt, for instance, the right ventricular outflow tract, and there are descriptions of the mitral valve which I completely ignore because I think it is not really serious to do that. And we are calculating this flow area by multiplying this flow area afterwards with the velocity time integral across this flow area. And the second method to do volume measurements is that we do it with volumina of the left ventricle, perhaps in some cases of the right ventricle, but also, as I told it, for the area of the mitral valve inflow region, I do not really believe that it can be used for routine work. So we have always to ask in all what we do if it is plausible what we do, and we need to know the standard conditions where these measurements can be done in a serious way. So let's talk again about this continuity quotient. you are calculating, everybody knows this, the stroke volume is the area times the velocity time integral. What is the area? The area is half of the diameter squared times p, and velocity time integral. All these two parameters have to be discussed and analyzed if they can be used in this specific patient. One thing which is really important is the left ventricular outflow determination. If you are aware of the situation that half of the diameter will be squared for the calculation of the area, you can imagine that these measurements that we are doing normally in our routine work for 1.9 and to 2.2 centimeters in this specific patient will give incredible high differences in the area calculated. That means that in this specific patient, you can have a severe or a moderate severe aortic valve stenosis. This is a true problem, and there are a lot of papers out, and just recently we saw a comparison of cardiac output with two-dimensional and three-dimensional transesophageal echocardiography compared to transpulmonary terminal elution techniques, and they found out very systematically analyzed in transesophageal echocardiography during cardiac operations that if you are measuring the left ventricular outflow tract just some millimeters below the annulus, or you are measuring without aortic stenosis the opening area, and you combine that to either CW Doppler or different kinds of analysis of the pulse Doppler echo, you can get reasonable results. And which is really interesting is that what we routinely do is that we are taking this subvalvular annulus, and we are taking the surrounding spectrum velocity. You will get the best results. This is one publication which comes out, but this really gives us some reasoning to continue our work at this field. The next what we have to think of is in our specific individual patients always what is the size of the area. We are taking only one diameter, but everybody knows from TAVI implantation of aortic valve prosthesis that the shape of the left ventricular outflow tract, the annulus, might be ellipsoid and it's oval shaped, and this is not always circular round. And this is a true problem. And you can see if you take the original, the true area by, in this case, by transesophageal echocardiography, or you take only the shorter diameter, this gives incredible high differences in the calculation of the subvalvular stroke volume. And this will also has an extreme consequence on how many patients, for instance, you will find with normal flow, low gradient aortic stenosis. If you take the oval-shaped orifice area, then you will have 61% of those patients who have been defined before only by taking the shorter diameter as normal flow, low gradient aortic stenosis, who have definitely a moderate severe aortic stenosis. You must keep that in mind. I do not want to stress that you always have to take the complete area of the subvalvular annulus size, but it should be mentioned that patients are different from their individual echocardiographic conditions. One other thing which has been discussed is the velocity profile. We are always thinking that when we are measuring the profile in the left ventricular outflow tract or in the right ventricular outflow tract, that this is a flat profile, which is not at all true. We have, during the pulsatile flow, we have acceleration zones and the profile changes over time. And you can see it, how the profile changes. These are technical analysis which you can directly pick out from the internet, and you see that in the acceleration phase this flattens the profile with time, and the same is true for the deceleration phase afterwards. So it is not at all, even if in a rectangular tube here, it is not always the case that you only find a flat profile. And the most difficult situation is that what we see in our patients, that we have curved, bended tubes in the left ventricular outflow tract, for instance. And there you must look for the directly to be analyzed velocity profile. And there have been some ideas out that you can measure the velocity profile across the subvalvular area, which is seen here in a model. And I will show you to you how it works normally in our routine work. You see here a patient with a bicuspid valve, severely symptomatic, and I go over to the next. And what we do, and what you should do in all these patients, you should take, if you have a 3D transducer, it's wonderful. Otherwise, you should take both planes in the 5-chamber view and the long axis. This is the other side, because it is a 3D transducer. You should look for the velocity profile under the valve where you are measuring the velocities afterwards. And this can be perfectly done if you take it in 3D echocardiography, and this shows that this is first of all an oval-shaped cross area, and you can surely see that it is not at all homogeneous flat profile. But we accept this compromise, and we are taking the velocity, and now it is the question, where do we take the velocity? And here you can see that we are approaching, we are approaching the valve step by step, and everybody says you should be just below the valve itself, but this is critical with pulse Doppler. What we normally prefer is that we take the shadow in this CW Doppler, and we are taking the velocity from this shadow and the velocity in the valve by the CW Doppler is the highest velocity, and we have the DVI, the quotient between the two velocities, as an indicator for severity. In this specific case, we have a very broad diameter below the valve with 2.5 centimeters that results in 0.9 centimeters square, which is just at the limit of to be a severe stenosis. And what we, and this is my personal opinion, prefer to do in all these patients, if there is little uncertainty about the severity, we take it with 3D echocardiography or with X-plane, and we planimetry the valve, and this is the easiest and the best way of sizing the orifice area. So we need to calculate the subvalvular stroke volume for the continuity quotient. And here you see a patient who has been operated in our department. He has got an Inspirus 23 millimeter valve, and he has got a Moro resection of the subvalvular area. And what happened still to that patient is he has a severe, though he has been resected here, severe subvalvular velocity increase, acceleration, which gives very high velocities already here in this area. And this is a typical case of all those patients who we are treating with aortic stenosis and typically the heart failure with preserved ejection fraction with small ventricles and subvalvular narrowing. And it is very difficult to get out velocity profile. in the subvalvular area. There are the high velocities, and if you're looking for this 3D cut through the valve, you can see here, even if it is a typical patient and not an ideal image, that there are extremely differences in the velocities across the cross-section. So we do not really rely on these values. And what we do normally, we are scanning with our CW through the valve, and you see that there is the acceleration in the lower part or the more apical part of the left ventricle, and here is the valve itself. And then it is difficult to find out what is the valve. We try to fix the valve itself, but we all know that the subvalvular velocity in this case through the valve, we have only 3.1 meter per second, and below the valve we have 1.3 meters. That is normal relation for a prosthesis, but it is difficult to understand and to explain to the people that with a fresh operated prosthesis you have such high velocities. What you can also do if you want to have the true stroke volume in these patients, and this is my topic of the talk, you have the pulmonary valve, which in some patients can be perfectly investigated from the subcostal view, and problem there is to measure the diameter. In this case, it is 2.1 centimeters guessed, and then you can calculate the aortic valve area by the same method as we did it before the subvalvular area. So we are quite happy that this specific patient, the 23 millimeter prosthesis has an opening area of 1.8 centimeters square. It is difficult and must be decided in patient individually if you can accept the method of calculating the stroke volume in the left ventricular outflow tract or in the right ventricular outflow tract. So the second topic for the measurement of the stroke volume is to do it by 2D echo or by 3D echo. This is a very early paper of Harald Becher and his group at that time in Canada already, and they told us that 2D echo is good and 3D echo is good with acceptable image quality for calculation of ejection fraction, but it is not at all good for volumes. This was true before the famous recommendations for cardiac chamber quantification came out by Roberto Lang, and this is the best summary of all publications which came out, and you all know that they explained us that we should take biplane measurements for measuring ejection fraction. You can add contrast, and this is a company interest or industry interest, that contrast is not accepted worldwide everywhere, and they say this is as correlated to MRI images the better method, or you can even take 3D echocardiography. We are using these methods, perhaps we are using, most of us are using the method of discs for 2D imaging, biplane 2D imaging for measuring ejection fraction, but nobody should really dare to say that this has been reasoned by the recommendation that you can calculate stroke volumes from these measurements. But nevertheless, this is the method where today those who are really very ambitious in measuring a true quantification of quantitative mitral regurgitation are measuring the stroke volume. This is Andreas Hagendorf from Germany, who has defended this true quantitative aspect. and he has just written a paper. I was co-author, but I retired myself from this co-authorship because I personally do not believe that. I do not want to explain to you everything, but they compare the stroke volume by 2D or biplane to the echocardiography to the left ventricular outflow tract, and then they create the difference between both and say that this is this regurgitant volume, or from that they can also calculate regurgitant fraction. I really do not believe that this is what we can do, and I'm in agreement with Paul Rayburn, which I know very well. I've been several weeks together with him in former times, and he underlines that transthoracic echocardiography and TEE are excellent for diagnosing mitral regurgitation and to have an idea if it is severe or it is not severe. But the true quantification, multi-detector is for intuitive valves or other valves which can be implanted by transcatheter techniques. But what he says is that senior cardiac magnetic resonance should be the reference method. I do not believe this because we have too bad experience and too little experience in our daily work with magnetic resonance imaging for measuring the stroke volume. This might be possible as for aortic regurgitation, but it is depending on the flow measurements and not on volume measurements, just by planimetry, the images we see. So we all know that PISA method has drawbacks in many things. One is the geometrical aspect, as you can see here in typical case where you have an eccentric, you have a P2 flail, and you have an eccentric inflow and outflow through the valve, and you cannot really use the PISA method. And by the way, I never take the zero shift, because that what you see here is representative of what you do with zero shift. You are not linearly increasing only the size of the Nyquist limit, you are also changing the amount of backflowing blood. So this is not really serious to take the PISA method for quantification regurgitated flow. What we can see here is a typical example of a pseudo-prolapse, pseudo-Barlow with paroxysmal atrial fibrillation. And you see end systolic, there is severe regurgitation, but how do you want to quantify that? This is very difficult to quantify. What is the argumentation for taking PISA or vena contracta or regurgitant flow via these methods if it is not continuously regurgitant over the whole cycle? What we prefer in these cases is that we take the orifice area itself and we do planimetry of the vena contracta, and we, in these specific cases, we have to add these vena contracta, and we believe at the end that we have semi-quantitative aspect that this is a severe regurgitation. What the guidelines of the American Society of Echocardiography propose is extremely difficult to do, and nobody really uses it, that you compare the left ventricular outflow tract stroke volume to that what flows across the mitral valve. This is, in my eyes, not serious, and one should really test in normal patients the stroke volume across the mitral valve to the left ventricular outflow tract, and you need a confidence interval which you have to define before. What we find, and which is really assuring us that in these patients we have done the right decision to operate that patient and to reconstruct the valve, is that you see that the ejection fraction this patient goes extremely down, but the ejection fraction is only one part of the story. The rest is that the stroke volume across the aortic valve stays constant, So you are losing the backward flow across the mitral valve, and the cardiac output remains the same. So at the end, I want to remind again that it is possible, in my eyes, if you respect the specific conditions for left ventricular outflow tract measurement, you can measure the cardiac output there, and you can even take a right ventricular outflow tract. Mitral valve is not serious if you want to calculate by velocity time interval, and left ventricular volume by 2D or 3D echocardiography remains very, very difficult to do. It depends on the configuration of the ventricle, and we routinely will not accept that as a quantitative aspect to calculate mitral regurgitation. So I thank you for your attention. Okay, jetzt kannst du deinen anmachen. Sorry. Sorry, I have...
Very interesting presentation. Is there any question from the audience?
No.
Okay, okay, thank you. Thank you very much.
Thank you.
Now for the next talk, I would like to invite Dr. Fleshman for your talk about STEMI and acute coronary syndrome. Challenging cases from the lab